Hello everyone and welcome to our Goodfellow webinar on Quiet Eye, Red Eye. My name is Dr. Courtney White and tonight I'm talking to Dr. Justin Mora, an ophthalmologist and senior lecturer based in Auckland. He has training in glaucoma, pediatric ophthalmology and laser refractive surgery including SMILE. I'll now hand over to Dr. Justin Mora. Thank you.
Thanks, Courtney, and thank you to everybody who's attending tonight. It's an honour to have the opportunity to speak with you on ophthalmology, and the topics, as Courtney outlined, are these: the red irritable eye, ocular trauma, flashes and floaters, and then at the end we'll have a few neuro-ophthalmic cases. This is a page from the Auckland Eye manual, a flow diagram to help you assess a red eye and hopefully come to the correct diagnosis. The Auckland Eye manual is available as a book, which you can get from me if you want, but it's available as an app, either Android or iPhone app, which you can just download, and it's got lots of useful flow sheets like this, but also a lot of information on ophthalmic conditions. A nice sort of reference tool if you want to access it. It's free. So we're going to start with probably the commonest thing that ophthalmologists see. I suspect the commonest thing you see in the eye realm, and that's irritable, uncomfortable, gritty eyes. So the two questions are, what's the most common cause of irritable, uncomfortable, gritty eyes, and what's the most common cause of watery eyes? And as it happens, the answer to both these questions is the same. And you've probably already guessed the answer is blepharitis or meibomianitis, problems with the function of the meibomian glands. Those glands lie along the back edge of the eyelid, behind where the eyelashes come out. There's 20 or 30 of them in each lid, and they're responsible for secreting oils into the tear film. Those oils are important for tear function. The tears evaporate off the surface of the eye too quickly if the oils are deficient or poor quality, and that leads to dryness. And in response to that dryness, the eyes will overproduce tears. So that's the reason it's the commonest cause of watery and dry eyes. A lot of people with blepharitis have, as you see on that lower picture, scurfs, the debris along the lid margins or the bases of the eyelashes, sort of dandruffy sort of material, which drips into the eyes and contributes to the irritation and the tear dysfunction. Treatment, as you'll be well aware, is hot compresses, and the purpose of the hot compress is to soften the oils. That's why we recommend it 3 or 4 minutes, at least once a day. I suggest using a wet pack. It holds the heat better than a face cloth, and certainly better than just splashing hot water on the eyes. Rest it over the closed lids for 3 to 4 minutes, followed by lid massage from top to bottom in the upper lid, bottom to top in the upper lid, to try and push the oils towards the lid margin. A lot of people also benefit from wipes, Systane wipes, lid cares, Sterilid. There's different brands, but little wipes that you can use to clear away that debris once you've expressed it from the glands. Tear supplements are often helpful from a symptomatic point of view. And I have a low threshold for giving a short course of Clausic ointment, a couple of weeks, to the eyelid margins. These people often have an excess of bacteria, and those bacteria secrete toxins into the tear film, which contribute to the dysfunction. Flaxseed oil is helpful. Flaxseed oil or fish oils, the omega-3s and 6s, can improve the quality of the meibomian oils. It's a very useful treatment in children. Hot compresses don't go well when you're under 5, whereas most children will tolerate flaxseed oil. For a child, it's just a half a teaspoon of oil each day, and it can turn them around in a relatively easy manner. For adults, we might use azithromycin in a short course, as noted there, and for more recalcitrant cases, maybe doxycycline, a longer course. For children, erythromycin, 200 milligrams daily. We have these new treatments, IPL, LipiFlow. These are treatments that we kind of reserve for those cases that don't respond to normal treatments. It's a heating system for the eyelids. It's available from quite a few optometrists now. We have it at Auckland Eye and our dry eye clinic. Thankfully not required that often. These other treatments are usually effective. Patient with papillary conjunctivitis presents with irritable, sort of itchy, maybe slightly sort of sticky eyes, and you see this appearance on their tarsal conjunctiva, this sort of slightly lumpy, mildly injected, gelatinous sort of appearance. We call that papillary conjunctivitis. And there are two main causes. One is allergic conjunctivitis, and it's usually distinguished by intense itching rather than grittiness, discomfort. It's often seasonal. There's often an atopic history, and we treat that with Patanol eye drops. You're probably familiar with Patanol. It's a mast cell stabilizer, but also has good antihistaminic activity. So it can be used twice a day for a lifetime, very safely. It can be used as required as well, which is kind of handy, and it's funded. Livistan's a purely antihistamine. I don't use that much these days. And topical non-steroidals occasionally. Oral antihistamines are not that effective around the eye. It's perfectly reasonable if they have rhinitis, sort of systemic allergic problems as well, but not particularly useful for isolated allergic conjunctivitis. And the other main cause of papillary conjunctivitis is the cold viruses, viral conjunctivitis. They tend to be more sticky rather than itchy. They're very contagious, as you'll know, and so the key thing is effective precautions, washing their hands a lot, throwing away tissues when they wipe their eyes, and not sharing towels with other family members. Anyone who's had it will tell you that they would hate to think they'd passed it on to someone else. They're self-limiting conditions, so the treatment's supportive. Sometimes cold compresses can give them some symptomatic relief. We use topical steroids infrequently. That top right picture is the corneal infiltrates that you can sometimes get with adenovirus. And in that situation, I might well suggest some FML, mild topical steroid drops for a week or two to help clear the infiltrates and lessen any potential scarring long term, but very sparingly, and probably best done by an ophthalmologist. The picture on the top left, I neglected that shows what's called vernal conjunctivitis. You'll see those little pale lumps around the limbus. They're collections of eosinophils, and they're typical of this vernal conjunctivitis, a type of hay fever, allergic conjunctivitis. Commonly occurs in childhood, can be associated with massive papillae under the upper lids, but still generally responds quite well to Patanol and occasionally steroids. Bacterial infections are really obvious. They're much more aggressive, more discharge, more chemosis, which is conjunctival swelling, much more injected. And obviously there's a risk of corneal involvement. If there's an epithelial defect, the bacteria will get in there and proliferate, and you end up with a horrible ulcer, as shown in that top photograph. And that sort of patient obviously requires specialist assessment, and we would admit them to hospital, take corneal samples for the laboratory, and keep them on intensive topical antibiotics in hospital until we're confident we've got them turning the corner. More low-grade bacterial infections we'll often treat in the community. We don't actually see that many, and I think that's probably because you treat most of them, and they generally do respond to chloramphenicol drops, ophthalmic. You'll all recognise this appearance. You may not be aware that 10% of all zoster is ophthalmic, and that's classic, obviously, but sometimes it's a bit more subtle. This is a woman I saw a couple of years ago, and that lesion on the side of her nose was the only dermal evidence of zoster. And that particular position on the tip of the nose, the side of the nose, is important because that branch of the ophthalmic division of the trigeminal nerve is called the nasociliary branch. And that's the same branch that serves the anterior segment of the eye. So if we see involvement of the side of the nose, then we have a heightened concern about the potential for uveitis or keratitis. In my opinion, anyone with zoster should have an eye assessment at some stage during the course of their disease. They can get a low-grade grumbling uveitis, which needs to be identified and treated. And the majority of them, of course, get discomfort, but nothing more than that. Now, this sort of appearance you'll recognise as a dendritic ulcer, classic for herpes simplex virus, and treated with topical antivirals. Any of these patients, I'm sure you would anyway, but all of them should come to an ophthalmologist. We'll treat them with antivirals, and then as they're settling, we may often add in some mild steroid drops to try and lessen the long-term scarring. They do tend to get scarring, which can affect their vision for a lifetime. And as you're probably aware, they can be recurrent too. So we've got to be very careful with them. It's both inflammatory conditions, inflammation of the wall of the eye. The top one, scleritis, a deeper inflammation involving the sclera, and very frequently associated with systemic autoimmune conditions. Someone with scleritis and their symptoms would be very intense redness like this, pain, quite a deep, boring, aching pain. We would always investigate for systemic associations. And the lower picture is episcleritis. This is far more common. It's often sectorial, so you just see a little segment of redness. It can be completely asymptomatic, sometimes a little gritty, sometimes a little achy, but nothing like the scleritis. And usually, again, self-limiting. So while the top one might require steroids or even DMARDs to control, the lower one will generally just go away without us doing anything. If it's unsightly and red, then topical non-steroidals such as Voltaren, Ocular can be quite helpful in settling that. Degenerative changes, very common in Australia and New Zealand because of our high levels of UV. You see a breakdown of Tenon's capsule, which is a layer of tissue underneath the conjunctiva, a connective tissue layer, which thickens and yellows like this. If you look at kiwis, you know, most of us have got a little bit of this because of our high UV levels. They can be unsightly, they can get red, they can get inflamed. Again, you can use decongestants, non-steroidal anti-inflammatories to help treat the redness. Because they're elevated, they do have a bit of a tendency to dry out. So if someone presents with one of these and they've got discomfort, then topical lubricants, just artificial teardrops, can be very helpful. And it's always a good idea to advise them to be more rigorous about wearing sunglasses to lessen the likelihood of them progressing. So this is a pinguiculum that sits on the conjunctiva, on the sclera. This is a pterygium, same etiology, but this one's extending onto the cornea. The indications for removing these, so again, very common, often, you know, not florid like this, often just a sort of slightly pink, but fairly pale extension just onto the edge of the cornea, and doesn't require any treatment, can be stagnant like that for years. If they're advancing steadily across the cornea, then we worry that they can potentially long-term affect the vision. If they're tight, they can pull on the cornea and distort it and create astigmatism. That might be a reason for removing them. And of course, if they are red and sore and don't respond to topical treatment. Removal involves shaving the pterygium away from the cornea. Usually the cornea is quite clear underneath. Sometimes there's some greyish scarring, which we can't get rid of. And then removing all the abnormal conjunctival and Tenon's capsule tissue in the pterygium. We fill that defect with a graft taken from the upper eye, under the upper eyelid, the conjunctiva from the eye, but under the lid where it's been protected against UV. And these days we just glue those grafts into place, and they generally heal very well. The recurrence rate's very low, about 2%. This patient presents with aching, light sensitivity, a bit of blurring, and these are the clinical features identified. You pretty much need a slit lamp, well, apart from the top left, you need a slit lamp to identify these other features. You may remember the names for these various features. Top left, where the iris, the pupil margin sticks to the underlying lens, that's called posterior synechii. The bottom left, those little clumps, white clumps, they're on the back of the cornea, on the corneal endothelium, and they're clumps of macrophages. Top right is protein, we call that flare, and the slit lamp beam. And bottom right is individual cells floating around in the anterior chamber. So flare cells, chorotic precipitates, and posterior synechii all help us diagnose uveitis. This is not uncommon. It's often recurrent. It's most commonly associated with HLA-B27, and other autoimmune diseases. It can be idiopathic, quite a proportion are idiopathic. If someone presents with a single first episode, we don't necessarily investigate that, but if they have recurrences or if they present with bilateral disease, if the inflammation's further back in the eye, not just the anterior chamber, but the vitreous cavity as well, then we definitely investigate them looking for a systemic cause. And the treatment is intensive topical steroids, which of course would be done by an ophthalmologist and occasionally an optometrist. This patient also presents with a red, light-sensitive, blurry, achy eye. That's what the anterior segment of the eye looks like. And there's one clinical feature here which will help you distinguish this from iritis. And it's shown there, the pupil. There's no posterior synechia, that's true. But if you had this patient in front of you and you tested their pupillary responses, you'd find that pupil was very sluggish. It wouldn't respond very well to your light. So a fixed mid-dilated pupil and an achy red eye points towards acute glaucoma. Just briefly, I'll explain the pathogenesis of this condition. You have to be predisposed. Most people who get acute angle closure glaucoma are long-sighted. If you're long-sighted, your eyeball's relatively short, meaning that the structures inside are relatively tightly packed. And there's a shallower distance, a lesser distance between the back of the cornea and the front of the iris. So again, they're predisposed. You'll remember the aqueous for the anterior chamber is produced from the ciliary body, which is behind the iris. So it flows over the surface of the lens and into the anterior chamber. As we get older, the lens thickens. That can create a relative resistance to that flow through the pupil. And there's a buildup of aqueous behind the pupil, which pushes the iris forward and blocks the angle. So that's the sort of final common pathway. If you understand that etiology, you'll understand why the treatment with a laser iridotomy works. If we blast a hole through the iris in the periphery and create a direct pathway through from the posterior segment to the anterior segment, the pupil block is relieved. The pressure in the two chambers equalizes and the iris falls back out of the way. The angle opens and the attack is reversed. The treatments and the pupil. Now, the reason that pupil's fixed and dilated is because the pressure has become high enough that it's obstructed the vascularity in the iris. The vascularity's collapsed. So the iris has become ischemic and that's sitting in its resting state. When people come in with this, we lower their pressure medically to get the iris moving. It's got to get below 40 before the iris will kick back into action. We put drops in to shrink the pupil and then we create the laser iridotomy. This is an emergency situation. You know, I would be more concerned about this patient losing their vision than even someone with a penetrating eye injury or retinal detachment. The pressure can get up to levels of 60, 70 millimeters of mercury. And to put that in perspective, 21 is the top end of normal. And it can cause ischemia, not just of the iris, but of the optic nerve. And these people can go blind within a day. So it's very important they get treated promptly. If you're in a regional location and difficulty accessing an ophthalmologist and you're confident of the diagnosis, then treatment with oral diamox, acetazolamide, 500 milligrams stat, 250 4 times a day can help tide the patient over until they can get to hospital. On to trauma. Of course, the commonest thing we see are abrasions, and most of them are very benign and will heal quickly within 24, 48 hours. Don't be afraid to put a topical anesthetic into the eye in order to do a thorough assessment. And I think this is particularly true in children. You will gain their trust if you tell them that you're going to make their eye stop hurting. You put the drop in. You can get a decent look, and certainly in an adult, you can measure the vision. So it's fine, perfectly safe to do it. Just make sure the patient doesn't pocket the drops and take them home. You know, having discovered how wonderful they are, they might decide they want to have some of their own. Very, very dangerous. You mustn't ever give anyone topical anesthetics. They will prevent corneal epithelialization. They will, because they anesthetize the cornea, they make the cornea ripe for infection. There's numerous case studies in the literature and many medico-legal cases where people have been taken to task for giving these out. The patients ended up with a terrible ulcer and going blind. So be very careful. The evidence for padding an eye with an abrasion is poor. I basically just asked the patient whether they want to pad or not. There's no evidence that it heals better either with or without. Always think of a foreign body cause. It's embarrassing if the patient comes back the next day and you find this and you didn't quite pick it the day before. Ocular burns can be horrible. For us, alkalis are much worse than adults. They penetrate the eye much more than acids do. They can damage the epithelium, the vessels, so you end up with a corneal epithelial loss and potentially an ischemic eye. Most of the sort of injuries, we often get calls about people who've sort of got something in their eye and how dangerous is it. The principles apply pretty much the same to everything. You need to put some anesthetic in so you can check the eye, and then you put some fluorescein in and see if there's an epithelial defect. If a patient has a pink sort of reddish eye but no epithelial defect, wash them out, but they're not likely to have any long-term damage. If they've got a sizable epithelial defect, it means it's a bit more severe. You might wash them out a bit longer and maybe put them on some antibiotic cream for a few days. The really dangerous ones are the ones who have had an alkali in the eye, for example, and the eye is white rather than red, because that means that the vessels have been blanched. The alkali has killed the conjunctival vessels, and that eye, whatever you do, will probably do very badly and end up like that picture down below with a vascularized cornea and a blind eye. The rule is irrigate, irrigate, and irrigate again. We set up bags of IV fluids and tape a cannula across the nose onto the cornea and just let it run. And if you do that, then we'll probably do it again when they come to hospital. Once they're in hospital, and certainly the bad ones, we would admit. We treat them with topical antibiotics, vitamin C, steroids, with care, and lubricants, because often their goblet cells, their tear function is really rubbish too. But again, the vast majority of these, the sort of home chemicals and things, most of them are completely benign. And again, if the eye's a bit pink, but there's no epithelial loss, you can be pretty confident it's going to be okay. You'll see this not uncommonly, a little rust spot on the eye. Any ferrous metal on the eye doesn't have to be there very long, and it will create a little rust spot. One little tip is to remove the metal straight away, but the rust itself can be very hard to remove and softens if you give that patient some antibiotic cream for a couple of days and then bring them back. You'll find it's much easier to take the rust out. I wouldn't recommend taking rust out of that particular spot right in the center there. I would send that to an ophthalmologist, but the more peripheral ones you can dig away quite happily. It's incredibly hard actually to perforate a cornea. Please, cornea, don't prove me wrong. There are little burrs and things you can use to get rid of rust. Personally, I just use the side of a 20 gauge needle and just use that to sort of tunnel out or shelve out the little bit of rust. Works very nicely. There's another foreign body. If you looked at that on the slit lamp, you'd quickly realize that's not on the cornea, that's inside the lens of the eye, so it's actually perforated. The only way to get rid of that is to take the lens out, so that's one for us. This is a case I'd like to highlight. So you can see that little dark spot at the top of the eye, yeah? Looks a bit like a foreign body. The clue that it's not is the pupil shape. That egg-shaped pupil is a sign that the iris has been dragged up towards that area. And what you're seeing there, that little dark spot, is actually a little knuckle of iris coming out through a corneal penetration. So it's an iris prolapse. After blunt trauma, of course, you can get a traumatic mydriasis. The pupil's sort of sluggish and it's sort of oval shaped and things like that. But this is different. That egg-shaped pupil pointing towards one side, there's another example there, indicates a site of perforation. So with that top one, we'd take it to the operating theatre, pop that back in and put a couple of little sutures in it. The one on the bottom will probably require a graft because there's actually a piece of cornea missing there. These cases can often have a formed anterior chamber because once the iris plugs that hole, there's no fluid leaking out anymore and the aqueous reforms and they can have a normal depth anterior chamber, that one at the top, they might have 6'9", 6'7", vision despite that perforation. So just be careful of that. High femur, we talk about macroscopic and microscopic. That's a macroscopic high femur, that blood level you can see there. Microscopic means there's no blood level, but we can see red cells floating around inside the eye. You might see that in some of our reports. We advise bed rest because the main risk with these, the main risk for sort of more serious complications is a rebleed. So we don't want to risk that. When these injuries occur, blunt trauma to the front of the eye will push back, just the force of the trauma will push back the lens iris diaphragm, and that can tear around the root of the iris or the angle of the eye, and that's where the blood comes from. Because you have a tear in the angle, there's a risk that the trabecular meshwork, the pressure drainage system, is harmed, and therefore there can be a long-term risk of glaucoma. So with these patients, we treat them with topical steroids until their inflammation and their blood clears. We have a look in the back of the eye to make sure there's no retinal breaks. That's actually incredibly rare. But they all get an assessment 6 weeks post-trauma, looking at the anterior chamber angle to determine whether there's been any trauma to the angle. If there is, then they're destined to have long-term follow-up for eye pressure checks annually for the rest of their life. We tend to farm most of these out of the hospital because they're covered by ACC. We tend to suggest that the patients get their follow-up done privately. When you get a high femur in a child, it's not always possible to examine their angle when they're little, so we just have to see them every year until they're old enough that we can put the little lens on it with mirrors on it that allow us to look into the angle to see whether there is any damage there. Subconjunctival hemorrhages, as shown below, they're sometimes traumatic. They're often not. People sometimes wake up with these. And of course, it's terribly frightening to look in your eye and see that bright red patch, but they're completely benign. Very rarely a sign of a blood dyscrasia or malignant hypertension or anything like that. These are people who are usually fit and well. Again, self-limiting. They will go a bit yellow as the hemoglobin breaks down. It's helpful for the patient to know that. It's kind of like a bruise, will go a bit yellow and will disappear over a week or two. They take quite a while. Most times are asymptomatic. Sometimes if there's enough blood under the conjunctiva, they do stretch the conjunctiva and they can be a little bit achy. So if it is achy, again, that's not necessarily a sign that it's anything worrying. It can just be a little bit more blood. And they can be recurrent. Be aware of that. I've had patients who, have had a number of these over months. And, the presumption is there's a weak blood vessel there that bleeds, mends, and bleeds again. You think we'd be able to look on the slit lamp and find that abnormal blood vessel and laser it or cauterize it or something like that, but you just can't. There's nothing you can do about them. So moving on, new onset floaters and flashes ideally would be seen within 48 hours. Only 5% of those with new onset floaters and flashes actually have a tear in the retina, and only a small portion of those go on to get a retinal detachment. But it's important because we can treat it, we can prevent a retinal detachment if we detect the tear early. These patients are often myopic. The pathophysiology here, so the vitreous in the back of the eye, it's sort of a jellyish sort of consistency when we're little. And then as we get older, it becomes more watery. It can get to a point where it's watery enough that it can no longer support itself and it slumps forward, it collapses. We call that a vitreous detachment. That is really common, and it's the commonest reason for new onset floaters. Sometimes as it collapses, it will pull on the retina and stimulate it. That's where the flashes come from. And sometimes it will pull hard enough to tear a hole in the retina. If there's a tear in the retina, some of that watery fluid can get underneath and start to peel the retina away. And that's where the retinal detachment comes from. People who are myopic, I said when we were talking about angle closure, people who are long-sighted often have relatively short eyes. People who are short-sighted or myopic, they tend to have longer eyeballs. And because they have longer eyeballs, the vitreous is a bit more stressed, and so they're more likely to get flashes and floaters, vitreous detachment, and also retinal detachments. Particularly those of sort of 6 diopters of myopia are more than the sort of higher risk group. If we see these people with their flashes and floaters and we find a retinal tear, so 1 in 20, then we can use a laser to kind of spot weld around the tear so the retina is adherent and fluid can't get in and peel it away. If it gets to the point of retinal detachment as shown below, then one of my vitreoretinal surgical colleagues would take that patient to the operating theatre, do a vitrectomy, remove all the vitreous, push the retina back into place with, depending on where the tear is, with gas or oil, and then use an endo laser inside the eye to spot weld it from the inside. So eminently treatable if it's caught early enough. We'll move on to some neuro-ophthalmic cases now. This is a patient who has a mild right ptosis. And the commonest cause of ptosis is poneurotic dehiscence. So as we get older, all our tissues get a bit lax, and so can the tendon for the levator muscle in the eyelid. And so the eyelid droops. And again, that's very common. You can tell that because the crease in the upper lid is particularly high. And when you test the range of movement, the range is fine, the lid just sits lower, so it's not a muscle weakness. What's notable here is on the same side as the droopy lid, there's a smaller pupil. If we did a pupil assessment, we'd find that in bright light, the pupils are relatively similar in size, but in dim light, the pupil on the left enlarges, but the pupil on the right doesn't change much. And that points to a problem with the dilator muscle on the left eye, rather than a problem with the sphincter muscle on the, on the right eye, rather than the sphincter muscle on the left eye. So the sympathetic pathway for that right eye is impaired, and that's, as you know, Horner syndrome. A small amount of the innervation, so most of the innervation for the upper eyelid comes from the third nerve, but a small amount comes from the parasympathetic system, which is why with a Horner syndrome you see a slightly droopy eyelid, and of course the pupil signs. And again, as you well know, the pathway for the sympathetic system is long, from the hypothalamus down the brainstem, spinal cord, up into the chest, up into the neck, on the carotid artery in order to get to the eye. And so any part of this pathway can be affected. Someone with a painful Horner syndrome, which this case actually was, you must consider the possibility of a carotid dissection, and they need thorough workup, obviously, because that's potentially fatal. The majority are relatively benign. It's not uncommon to have it as a congenital finding. I see a lot of children with asymmetrical nerves, and the majority of them are just physiological anisocoria, basically meaning they just have inborn abnormal pupils. Also very common. A small proportion of them will have a true Horner's. In children, we worry if it is a true Horner's because the commonest association is neuroblastoma. So if we make that diagnosis, we're kind of committed to doing urinary catecholamines and then getting them an MR scan from head to abdomen. Case 2, again, a ptosis, but in this case, a complete ptosis on the left eye. If we lift the lid, we find that the pupil is larger on the left again, as it was in the last case. But in this one, with the light, the pupil reacts poorly on the left eye. The eye is exotropic, divergent, and when we test the eye movements, we find that the eye has trouble adducting, elevating, and depressing. So now we've got a problem that affects the upper lid, the medial rectus, the inferior rectus, the superior rectus, and the pupil. And that, of course, is the third nerve. So this is a third nerve palsy. When we see these cases, we're particularly interested whether the pupil is involved or not. If there's no pupil involvement, and particularly if the patient's a vasculopathic, hypertensive, hypercholesterolemia, if they're particularly elderly, then we'll comfortably put this down to a vascular third nerve palsy. Watch the patient quite closely to make sure it's not progressive. And of course, the vast majority of these will repair themselves over 6 weeks, 3 months often. So we take a conservative approach. If the pupil's involved, then that more commonly suggests a compressive cause. And the commonest compressive cause is a posterior communicating artery aneurysm. So if a patient presents with a pupil involved third nerve palsy, then they will get an MRI, MRA to look for that diagnosis, or another type of compressive phenomenon. Case 3, this is a 42-year-old man who presents complaining of difficulty parking his car. He's got perfect vision, both eyes, 6/6 both eyes. In this case, a normal pupil examination, no afferent pupil defect, normal pupil responses. Colour vision he struggles a bit with, but about 5% of males have red-green colour confusion, so that's not particularly unusual. When you test his visual fields with a red target, which is a useful thing to do, you become suspicious, refer him for formal visual field tests, and it shows, it shows this, a bitemporal hemianopia. A bitemporal hemianopia points towards pathology in the chiasm. In a child, we worry about a craniopharyngioma coming up from below. In an adult, most commonly a pituitary tumour coming down from above. And that's in fact what this man had, a large pituitary tumour. He had surgery, and those are his visual fields only 2 months after his surgery, in fact, I think 6 weeks after his surgery. A massive improvement, recovery. The key thing here is early diagnosis. You know, visual fields can be tricky, and I would urge you, and any patient who comes along with sort of vague visual symptoms, always make an effort to assess their visual fields, at least a confrontation. And if you're concerned enough, send them to an optometrist or an ophthalmologist for a formal visual field test. It is easy to miss subtle things, particularly things that come close to fixation. Even if they're not large areas like these, if they come close to fixation, sometimes a patient will complain of difficulty scanning a page, difficulty reading, because they've got a little blind spot in the center of their vision, which they're sort of aware of but can't kind of pinpoint. Again, time is the key here. The longer the optic nerve's been compressed, the more damage is done to the nerve fibers. We have a test called NO-CT, with which we can measure the ganglion cell layer in the retina and the nerve fiber layer in the optic nerve. If the OCT scan's normal in a case like this, we can be confident there's going to be good visual recovery once the nerve's decompressed. If there's already ganglion cell and nerve fiber layer loss, then the prognosis is much more guarded. Mr. SH, 53 years old, a 4-week history of headache, especially in the early morning. That's your first warning sign, isn't it? Vision perfect, which it often is. Ishihara color vision plates are good, and that's helpful. Color plates, you know, for people who have normal color vision, color plates are helpful for ruling out optic nerve pathology, optic neuritis, optic atrophy, and again, the pupils are normal. You look in the eyes, you do a visual field test and you see this. Now that would be hard to pick up with confrontation, that sort of left inferior quadrantenopia because it's relatively subtle, you probably need a formal visual field like this to pick it up. But on the field test, it's quite obvious, and leads to a optic nerve examination, which shows papilledema. And this might not necessarily have been the case. You could easily have all these features but still not have papilledema. And there's the right parietal glioma, which is responsible for the visual field defect. But again, and that's that size, it might not necessarily have caused raised intracranial pressure and papilledema. So you're really relying on the visual field test to pick that up. The last scenario I want to go through is a patient with intermittent loss of vision. And it's very important to differentiate between unilateral and bilateral simultaneous. Bilateral simultaneous suggests vertebro-basilar problems, or much more commonly, migraine. Migraines, we see a lot of people with migraines. Be aware that many headaches of all sorts, tension headaches, sinus-related headaches and things, can isolate to the eyes and the orbits. And the vast majority of people who complain of headaches around the eyes don't have eye problems. I mean, it's always a good idea to get them check their glasses checked by the optometrist and have a look in the back of the eyes and so on. But the majority of them are just simple tension headaches. It's generally teens and young adults who have the classic migraine with the visual auras preceding them, and then the intense headache, nausea, and photophobia. As we get older, the nature of migraines often change. In fact, it's true in children too. I see quite a few children with visual symptoms which I ascribe to migrainous auras, and commonly there's a family history of migraine in these kids, and also true in older people. I had 2 migraines as a young person, the classic ones, and then just over the last year I've had a couple of classic visual auras, migrainous auras. And they can present differently. The ones I get and that are very common are what we call the fortification spectra, that sort of scintillating circle of light in the vision, again, by both eyes simultaneously. Some people get hemifield loss. Some people get contraction of the visual field down to sort of tunnel visions, all sorts of types of visual auras. And as you'll be aware, the auras come from overconstriction of blood vessels, and the headaches from overexpansion. So it makes sense you can have one without the other. Beware of the patient who has consistently unilateral migraines, because that's atypical, and they probably do warrant imaging. So when we come to intermittent loss of vision that's unilateral, that's potentially more worrying. This is a case where the person describes a sort of curtain coming across the eye, which then recovers spontaneously over 15-20 minutes. Monocular painless, can be asymptomatic, and when we see these patients, we look for retinal emboli thrown off from the carotids. So we listen to the bruit. It's probably the only thing I ever use a stethoscope for, I'm afraid to admit. Listen for carotid bruise, and have a low threshold. If they have a retinal embolus or suggestive symptoms, they need a Doppler, and generally we get a cardiac assessment to maybe an echo to look for sites in the heart. This is the appearance of a superior, on the left eye there, a superior branch retinal artery occlusion. You can see the pallor in that top part of the retina. They can recover spontaneously. The branch ones not uncommonly do. So they get the symptoms, then the plaque moves on, the symptoms go away. That's the sort of 15-20 minute thing. This is a central retinal artery occlusion in a right eye. That sort of highlighted area in the middle, that's the macula, the fovea. We call that a cherry red spot. And in fact, that's just the normal foveal color, but it's surrounded by all this pale retina, ischemic retina. And sadly, central retinal artery occlusions very rarely recover. We try all sorts of things to improve them. Massage is recommended, but I've never seen a case where massage makes any difference. If they have elevated pressure, sometimes we'll decompress their anterior chamber to suddenly drop the intraocular pressure to see if that will move the embolus along. People have tried hyperbaric chambers and so on, but very rarely does any of this make any difference, unfortunately. And of course, when people get temporary loss of vision, we worry about giant cell arteritis. The symptoms you'll be familiar with, the temporal headache, generally associated with thready, non-pulsatile temporal arteries. I'm quite reassured if I can palpate a temporal artery and it's happily pulsing away. I'm more comfortable that it's not temporal. They don't have temporal arteritis. Jaw claudication is common, sometimes confused with TMJ problems, tooth problems, and so on. But it's, you know, in reality, it's kind of classic. They get pain with extended periods of chewing. They can also get fleeting binocular diplopia. So someone who has intermittent diplopia, that's always on our differential diagnosis. And of course, malaise, anorexia, weight loss and night sweats, and polymyalgia. Pretty uncommon under 60. So you should feel much more reassured if the patient's younger. And if in doubt, of course, ESR and CRP, which are usually pretty well elevated, as are the platelets. Temporal artery biopsy is indicated if we are suspicious enough. I mean, we get referred a lot of cases of possible giant cell arteritis through our acute service, and many of them we don't take any further. But if there's any question about it, a temporal artery biopsy is warranted. Occasionally, we'll get a negative biopsy and actually do it on the other side as well if we're convinced enough of the diagnosis. The rationale behind doing the biopsy to prove the disease is, of course, these people are on pretty high dose steroids for a long period of time, and that carries a lot of morbidity with it. So we want to be pretty confident that we're making a correct diagnosis. This is another urgent problem, particularly if someone presents with loss of vision with signs of giant cell arteritis. That's often a ischemic optic neuropathy. So they've lost the blood supply to the optic nerve, probably cannot be turned around once it's, you know, if they've dropped down to 660 vision from that, we probably can't reverse it. But the danger is it could happen in the other eye. And I've seen that where people come in with loss of vision in one eye, and within a couple of days, they've lost the vision in their only remaining eye. And sometimes this is despite everyone's best efforts getting them onto steroids very promptly. And a slow taper, obviously, based on the inflammatory markers. So that's all. We've covered the red, irritable eye, ocular trauma, flashes and floaters, and these handful of neuro-ophthalmology cases. I hope that's been helpful. I see there's a few questions in the Q&A, so I guess we could move on to the questions.
Right. Justin, thank you. That was an excellent discussion and overview. A few questions cropping up. A few people asking if the app is still up and running. We can't find it on the App Store.
Oh, you'll have to let me check on that. It should be. I'll have to, Courtney, can I let you know?
Yeah, absolutely, yeah.
It may be a way of getting an update or something like that, but as far as I'm aware, it's still on there.
Okay, sure. We can let attendees know your answer.
Thanks for looking.
There is a PDF available if you Google Auckland Eye Manual through the Auckland Eye website, so you can bring up the PDF.
It would be a massive PDF because it is a book about this fat. So no, but we certainly used to have print versions of it, and I imagine we still do. Do you want? I'm happy for people to have my email address if they want to email me, and I can see if I can get them a copy.
Oh, sure. Okay, great. We can set that up. Yeah. What are the funded topical NSAIDs available?
Yeah, so short answer, none are available at all at the moment. During COVID, the country ran out of topical non-steroidal anti-inflammatories. There's one around at the moment called Levro, which we can get funded through a special authority. But generally Voltaren is the funded one. Be aware that they can be quite stingy when they go in. So warn the patients of that. You know, if they're having it because their eyes are uncomfortable and then you give them a stingy eye drop, they might not thank you. But they can be quite good for those inflammatory conditions, for settling down the redness.
Are Morgan lenses still used for irrigation?
What lenses, sorry?
Morgan lenses?
Oh, probably answers your question, not that I'm aware of.
Okay. Next one is Seidel's sign reliable in penetrating injuries?
Well, not always. You know, those cases I showed you, the iris is plugging the hole. So that would be what we call Seidel negative. The Seidel test, for those who aren't familiar with it, involves putting a drop of fluorescein in the eye and then at the slit lamp looking with cobalt blue light. And you can see if there's fluid leaking out of the eye, you can see the fluorescein being washed away from the little waterfall of fluid that's draining out of the anterior chamber. But again, if the iris is plugging the hole, it could be Seidel negative with a formed anterior chamber.
At the very start, you mentioned using flaxseed oil for blepharitis. I assume that's oral supplement.
There's some debate about whether flaxseed oil is any better than fish oils, and to be honest, I don't know the answer. But it's the omega-3s and 6s that seem to be quite helpful. Both anecdotally and in the literature, there's good evidence that it can be useful. So it's such an easy one. For adults, just get them to take the capsules or the syrup if they'd rather, and yes, orally. For kids, half a teaspoon of the syrup could be really useful.
Someone said they often see what they call concretions inside the lower lid in irritable eyes. They look like small white papular lesions. Yeah. What are they and how do you treat them?
They are concretions, and they're little calcific deposits. They're not uncommon at all, you're quite right. Most of the time, if you have access to a slit lamp, you can see that they have a little covering of conjunctiva over them. Only the ones that break through the conjunctiva actually irritate the eye. If they break through the conjunctiva, they're actually very easy just to flick out with the tip of a needle because they've got nothing covering them. They sort of shell out like a little pimple, I suppose. So yes, they are common. They're not a common cause of irritable eyes, though.
Someone said people often report floating dark spots in the vision which gradually settle. Yeah. Are these benign and nothing to do with a vitreous or retinal detachment, or caused by degenerative changes in the vitreous? So
they are caused by degenerative changes in the vitreous, and they are floaters, and they're really common. I've got some that I've had since I was a kid. And they kind of waft in and out of my vision every so often. So the long-standing floaters that come and go are fine. Really common. I bet you tons of people on this Zoom meeting have got them. They come and go. So the vitreous, you can get changes in the vitreous that release denser components. So it becomes more watery, and you can get denser bits becoming released and drifting around. So that's where you get the floaters, but not necessarily a vitreous detachment. Over time, as the vitreous becomes more liquid, they tend to, just gravity takes them down to the bottom of the eye, and so you don't see them so much. And then sometimes they'll waft up and get in the way of your vision. They can be postural, so if you're lying on your back looking at a white ceiling, you might see them, but when you're up and about during the day, they may disappear. So long-standing floaters, not really a problem. New onset floaters, particularly with flashing lights, we worry about retinal detachment. There are other causes of new onset floaters too. Sometimes inflammation, clumps of inflammatory cells or blood can cause floaters too. So it's the sudden change that you need to be a bit wary of.
Sure. Someone has asked, what happens to the temporal artery after it's been biopsied?
If it's an arteritic artery, it kind of won't make any difference because it won't have any blood flow in it. But if we happen to take a good one, well, I guess that's knackered then, isn't it? But never seems to cause a problem.
Are oral anti-inflammatories okay for episcleritis?
Yeah, they're fine. Most times they're not needed, but yes, they're perfectly safe. In fact, we sometimes use them for scleritis too.
If we refer a patient to an optometrist to have their vision checked, say in the context of a headache, would that include visual fields normally?
Yeah, we're very fortunate in New Zealand. Our optometrists are very well trained. Anybody going along for an eye check at an optometrist, they'll get their glasses checked. But they will always have an eye examination as part of that. So the optometrist will put them on the slit lamp and check their nerves, check their pressures. They often do routine visual field tests as part of their assessment. Some of the optometry practices have the OCT I talked about, so they can do scans of the retina and they can do scans of the optic nerves. Many of them will take routine photographs of the back of the eye and so on. They use it as a bit of a marketing ploy, but in fact, it's really useful. So an optometrist is a good first port of call if you've got concerns.
Someone has a case of a patient with intermittent unilateral ptosis and patient only during sex. They've had it for years, no other signs, and their visual acuity is perfect. Any ideas?
Oh, that's fabulous. Okay, vascular, do you think? Blood flow going elsewhere, perhaps? That's the thing that springs to mind. For someone, not in this case, but for someone with an intermittent ptosis, the thing that always springs to mind is myasthenia. But I can't imagine that seems unlikely in that case. I'm not sure. I love it though.
This is about shingles. If someone has shingles away from their eye or face, but they have eye pain around the same time with no redness, no visual disturbance, would you still be suspicious of ophthalmic involvement?
No, it's really got to involve the nerves to the eye. So it really has to be the ophthalmic division of the frontal nerve that's involved. So if they have it in a different dermatome, then no, they won't have eye involvement.
If someone has had a history of shingles with ophthalmic involvement, are they still able to have the shingles vaccine?
Oh, I think so. Yeah, sure.
Some people have just come through and said the Morgan lenses are used in ED for eye irrigation.
Nice. Don't think I've ever seen one.
Do you have any preference for lubricating drops, and is it better to be preservative free?
In principle, it's better to be preservative free, but they're much more expensive, and most people are fine with preservatives. People respond differently to different sort of preservatives, so it's hard to say that one's necessarily better than the others. Polytears is funded, so that's helpful. Cystane, there's various sort of brands of cystane, different sort of consistencies. Cystane Ultra is a more watery one. Cystane Complete is perhaps a bit more sort of physiological. I think you've just got to get the patient to sort of try them. The preservative-free ones are those ones that come in the little vials where you break off the top and you can reuse it through the day, but you need a new one each day, and therefore the cost adds up. And again, while they're sort of physiologically nicer for the eye, the vast majority of people, they're not necessary.
Is it okay to use steroid drops in primary care, for instance, for allergic conjunctivitis, if we're finding that antihistamines aren't effective? Sometimes patients are requesting this. If it is suitable for primary care, which one do you use and how long is it safe for?
Yeah. The short answer is no. I mean, I'm glad you asked. The short answer is no. And the big concern for us is pressure problems. In long-term steroid use, people will get cataract, but particularly in children, you're probably familiar with what we call a steroid response, where you put topical steroids in the eye and the eye pressure goes up. Particularly in children, they tend to get a much higher pressure. The research tells us that 50% or more of children with dexamethasone, Maxidex eye drops, will get a pressure rise of more than 15 millimeters of mercury, and it can happen within days. A pressure rise like that, can compromise the optic nerve within a couple of weeks. And again, there are numerous medico-legal cases and case studies in the literature of people who have lost their sight from injudicious steroid use. And as much as you might tell the patient, only use it sparingly or don't use it for more than a week, if it works, they'll just keep putting it in. So I would have to say, no, I don't think you should use steroids in primary care.
Is there any significance in when you're looking in the back of the eye, you have a nice clear optic disc edge, fundus, everything looks fine, and there's just a little bit of pigmentation around the edges of the optic disc?
Yeah,
is that of much significance?
It's quite common, eh? Yeah, no, there's no significance in that. It's just a reflection of how the choroid, how close the choroid and the retina and the retinal pigment epithelium come to the optic nerve. So sometimes you see a little pigment crescent. Sometimes you see a sort of pale white crescent, which is sclera, a little scleral band, and that's perfectly fine. It's just a variant of normal.
Someone has asked, a patient with unilateral ptosis, mostly in the morning, gets better during the day, their vision is fine. Any ideas, any concerns?
Yeah, I would still, I mean, the differentiations between myasthenia and just an aponeurotic ptosis, the droopy eyelids that come from aponeurosis dehiscens, so, the stretching of the tendon, they tend to be variable during the day. They, particularly later in the day, as people get tired, it gets a bit more droopy because it's harder work holding it up. But sometimes you can say the same about waking up from sleep. You're a bit sleepy and not so much effort going into it, and the lid's a bit lower. And then when they're up and about and active and everything's happening, they're keeping their eyes wide open. So it's always that differentiation between an aponeurotic thing and myasthenia. And myasthenia is really uncommon, and there are some clinical features like that higher skin crease, normal range of movement in the eye. Not the sort of classic worse when I'm tired at the end of the day. That's helpful in differentiating myasthenia. Unfortunately, myasthenic antibodies are not particularly sensitive for ocular disease. We don't get a high hit rate. So a lot of them, you do the blood testing and they might be normal. And sometimes the only way to tell is to do a tensilon test.
Does starting prednisone before a temporal artery biopsy affect the result?
No, there's an acceptable sort of window where, if we do the biopsy within about 3, 4, 5 days, we can still get a positive result. If the level of suspicion is high, it's just such a devastating thing when people lose their sight from an ischemic optic neuropathy from giant cell arteritis, because of course it's avoidable. So please don't let that stop you from treating someone if you're convinced that that's the diagnosis. If we don't agree, and if we get a negative biopsy and decide to take them off their steroids, well, maybe that's over 2 or 3 weeks. We taper them off. It's not a disaster.
Do you have any recommendations for when or how often patients should see an optometrist, just for eye screening, just a general check?
Yeah, that's a great question. I should have mentioned that. And there are published guidelines on this. We tend to follow the American Academy of Ophthalmology, and it increases as you get older. So the rule is from the age of 40 every 5 years, from the age of 50 every 3 years, and from the age of 60 every 2 years. And the logic is, when you're having these routine eye tests, You're looking for macular degeneration. Well, that's really much older people. But the main thing is glaucoma. And while glaucoma is generally a disease of over 60s, it's not always. I see babies with glaucoma sometimes, young adults with glaucoma, and therefore, obviously you can't test everybody, but that's the logic behind starting at 40. Reinforce that message if there's a family history of glaucoma, a first degree relative affected, because there's a strong link. Your risk is about 5 times, really high, if there's a first degree relative, mum, dad, or sibling with glaucoma.
We've got another case, a bilateral pulsatile yellow hue in the center of vision experienced by a patient only when they're in a hot shower.
No, you got me stumped.
Refer maybe.
I'll keep thinking about it.
We might be able to tee this up later. Someone just wanted a picture of how the eye is irrigated, how you described it.
Well, I'd use a Morgan lens. No. So literally a bag of fluid on a stand, the plastic part of the cannula, obviously with the needle gone, but just taped across the bridge of the nose, a speculum, and then just let it drip. If they've got a bad alkali burn, the eye will be anaesthetic, sadly. Again, that's another poor prognostic sign. If it's not anaesthetic, then of course put anaesthetic in. But if they don't need it, then it's a bad thing. But it's pretty simple to set that up.
And if we didn't have a specific cannula in primary care, is there anything else we could use? Well,
just get the patient to hold their eye open, or relative to hold the eye open. But it's got to be open, obviously, for the irrigation to work. One of the troubles is that when the alkali gets into the tissues and you sort of wash the eye out, when you stop, it emerges from the tissues back into the tear film, and so the process just continues. And that's why irrigating for a long period of time is so important, with sort of copious amounts of fluid.
Someone said saline through nasal prongs works very well.
Oh, fine. Yeah, cool. I like that.
Someone has said, is it appropriate to refer a child with inverted eyelid and the hairs irritating their eye?
Yeah, I see quite a few of those. It's called epiblepharon. If you look at those kids, and it's often Asian children, they have kind of an extra little fold of skin on their lower eyelid, and it directs the edge of the eyelid upwards, and the lashes are quite vertical. And sometimes, particularly on the medial side, they can actually touch the eye. It's generally completely benign. The lashes in children are very, very soft. Sometimes it'll make the eye a little bit watery, sometimes a little bit sticky, but often nothing. Very, very unlikely to abrade the cornea and cause any injury, any long-term scarring. And almost all of them will sort themselves out as the child grows. That fold, that epiblepharon, often improves, and the lashes become a bit more forward directed and no longer touch the eye. It's pretty uncommon for us to have to operate for that. We can take out a little ellipse of skin and invert the eyelid, but it's pretty uncommon for that to be necessary.
Any evidence behind vitamin supplementation or dietary changes for those with macular degeneration?
Yeah, there's good evidence that the sort of classic Mediterranean diet can be helpful. You may be aware of vitamin supplementation that we actually recommend for people with macular degeneration, MacuVision with lutein. There are a couple of big studies called the ARID studies which looked at this, and the summary of those studies is that there was no proof that it was valuable as a preventative. There was no proof that it was helpful for people with very low-grade macular degeneration. And if people had very advanced disease, it was too late. But for those with moderate disease, there was a statistically significant lessening of visual loss. It wasn't massive, it was like 20%, but it did lessen the chance of visual loss over time. And, if it was me, I'd I'd take the dietary stuff. I might not necessarily take the tablets, but that sort of Mediterranean diet, yes, I would.
Okay. Any tips for differentiating, say, conjunctivitis versus a blocked nasolacrimal duct in infants?
Yeah, I mean, conjunctivitis will, if you treat it, it'll go away and it won't come back. For instance, with a nasolacrimal duct obstruction, what's happening is the tears are getting into the tear drainage system and pooling. The bacteria get in there and proliferate, and you get all this muck washing back out over the eye. The key clinical differentiator would be red eye. So, for example, with conjunctivitis, you'd have a red eye. With the stuff just washing back out over the eye, sometimes it's a bit irritating on the eyelid. The eyelid can get a bit red and a bit raw looking, but the eye itself is not usually injected. And again, if you treat it, you might fix it for a few days and it'll just come back again. You'll be aware that 95% of them resolve spontaneously, so we don't rush to treat them. And ADHD, any children we're referred with nasolacrimal duct obstruction with those symptoms of a chronically watery, sticky eye, under the age of 1, we decline those referrals because we're not going to do anything with them. Once they're over 1, they go straight on the waiting list. We see them pre-admission to confirm the diagnosis, and then they get a tear duct probe, and we put a little probe down and unblock them, which has an 80% success rate. So most of the time it sort of fixes them for good. But again, reluctant to do that until they're over a year of age. Mainly because of the anaesthetic risk, we don't want to put babies to sleep if we don't have to. In terms of treatment, it is just supportive. I mean, it's really hard for families. One of the things you can tell them, which I think is really helpful, is it's not conjunctivitis because the eye's not red, and they're not contagious because they get all sorts of stuff from daycare and all that sort of thing. So you can reassure them on that front.
Excellent. Well, that's all our questions. So thank you very much again, Justin, for joining us. And to everyone else, thank you for joining us as well. Just a reminder that this will be online on the Goodfellow website tomorrow, along with a list of any relevant resources. So have a lovely night, everyone.
Thanks, Courtney. Thanks, everybody. Appreciate you attending.